Welcome to the latest edition of the College of American Pathologists CAPcast. I'm Becca Battisfor, Content Specialist with the CAP. In this episode, Drs. Edgerton and Fanburg-Smith will be talking about bone and soft tissue cancers. July is Sarcoma and Bone Cancer Awareness Month. Sarcomas are rare cancers in which malignant cells form in the bones or soft tissues. There are currently 70 different subtypes of sarcomas divided into two categories: soft tissue sarcomas and bone cancers. Medical News Today has found that 1% of all new cancers diagnosed each year are bone and soft tissue cancers. The American Cancer Society estimated that of the sarcomas diagnosed each year, approximately 13,000 are soft tissue, with another 3,500 as bone cancers. And now I'll let our guests introduce themselves and dive into the questions.
I am Dr. Mary Edgerton. I am an anatomic pathologist. I worked at MD Anderson for, I think 17 years before I retired recently, but I didn't completely retire. I've moved to the University of Nebraska, where I'm heavily involved with pathology informatics and some breast pathology. Talking about the electronic cancer protocols and cancer is a subject that I am fascinated by and I have worked on for many years. I am actually the chair of the Pathology Electronic Reporting Committee, which formulates the electronic models for the cancer protocols. We are coming out with some updated protocols for bone and soft tissue, and so we have invited Dr. Julie Fanburg-Smith to tell us a little bit about osteosarcoma and soft tissue tumors. Yes, those tumors that strike fear in the heart of every resident. Oh my gosh, it's just some pink stuff with just a few nuclei. What is this? So let Dr. Fanburg-Smith introduce herself, and then we'll talk about osteosarcoma and bone and soft tissue tumors.
Great. Well, thank you, Dr. Edgerton, for this kind invitation to speak with you today. And I am, just to give a little background about myself, I'm currently a professor of pathology, pediatrics, and orthopedics at the Penn State Health College of Medicine Children's Hospital and Milton S. Hershey Medical Center. There I do a lot of things. I wear a lot of hats. So I'm actually a senator, the chair for the academic affairs, and I direct the musculoskeletal pathology unit. I really love teaching, and we have a lot of trainees, anywhere from visiting high school students to college students to medical students and residents. Of course, I teach every day. We also do research together, and we collaborate on several types of interesting areas, anywhere from non-neoplastic Charcot-neuropathic arthropathy mouse model to studying tumors, including these very new tyrosine kinase fusion sarcomas. We can talk about these in a minute as we go through some of the newest and targetable sarcomas that are really interesting. I usually have a very specific approach to diagnosis, and we'll talk about that also as we go along. And I'm involved in several committees, but most importantly for the CAP, I have been involved with CAP for many years. I've given soft tissue seminars, but I also notably was a member of the SurgePath committee and wrote some of the PIP cases, and that was very enjoyable, a great group. And currently I am part of the cancer committee, and I also help with the biomarker reporting. And we're currently working on, this very minute, we're working on the bone and soft tissue protocol. So this is going to be an exciting time for bone and soft tissue.
Oh, excellent. Well, to start, bone and soft tissue tumors are not very common. Can you just tell us a little bit? And you also mentioned you're a pediatric pathologist, and I know that the pediatric soft tumors are a completely different textbook than the adult soft tumors. Can you just tell us a little bit about the populations most affected by, and let's start with osteosarcoma and focus on that.
Sure, thanks for asking. There's many bones in the human body, 206, and probably almost all of them can develop osteosarcoma. But osteosarcoma is the most common type of primary bone malignancy in children and young adults. So that's the age population. Osteo, we know, is the word for bone, for the Latin or the Greek word, and sarcoma is a malignant tumor that involves connective tissue, including bone, cartilage, fat vessels, nerve, and muscle. There's two age peaks for osteosarcoma, particularly for conventional high-grade osteosarcoma, which is the most common types. These mainly occur in children, teenagers, and young adults between the ages of 10 and 24. They arise in the metaphysis of the appendicular or long bones, usually around the knee. So a classic scenario is that a child will be playing soccer or something, to get hit in the knee by a ball. They go in for radiologic imaging and unfortunately discover that they have a osteosarcoma, only to think back that all that pain they had for the last several months was probably not sports related and most likely due to the tumor. And so that's the first group and the most common group. The second group of osteosarcomas occur in the axial or central skeleton, which is the jaw, the spine, the pelvis. And these are usually in older adults, anywhere between 65 and 74. These also, when we call something in soft tissue, such as an extraskeletal osteosarcoma, these may even occur in an older age group, like in the 80s. So the types of osteosarcomas that we usually think about is separating high grade and low grade, and there's several different subtypes.
One of the other things that I remember from my residency is you need to have an X-ray of the specimen. So can you just tell us a little bit about how you start to evaluate the specimen once you get it?
Absolutely. In fact, absolutely. We work very closely with our musculoskeletal radiologists on a daily basis. I have usually talk with them or meet with them once a day and go over all of the bone and soft tissue cases. And so the diagnosis of bone tumors particularly requires a clinical, radiologic, and pathologic correlation diagnosis. We never make the diagnosis under the microscope without looking at the radiologic imaging and get the clinical history. And this goes for many subspecialties, but particularly for bone and soft tissue. And we'll talk in a minute. When we talk about treatment, we're gonna talk about our team that we work with, the sarcoma group that we work with on a regular basis, and we meet together and go over all of the cases that we have, particularly sarcomas.
You know, I know that this podcast is for pathologists, but I always like to mention that a lot of patients don't realize who pathologists are and what they mean to the patient and how integrated we are. It's as though you look at a picture of all your doctors and there's this missing face, which is us, the pathologists. But just, you did mention something about, different subtypes of osteosarcoma. So let's go into that a little bit.
So basically we have the central conventional osteosarcoma, which is the most common type, and that's usually in the long bones. And then we have a low-grade central, or sometimes it more commonly manifests on the surface. It's called a paraosteosarcoma, which is a low-grade osteosarcoma. And these have a very distinctive and characteristic finding by FISH. We can see an MDM2 amplification to help make the diagnosis. These can be particularly tricky in a small biopsy, and so sometimes MDM2 can be very helpful, in addition to the morphology. The difference between the two subtypes, high versus low grade, include in the high grade to see features of malignancy, high grade malignancy in the background for a high grade osteosarcoma, including pleomorphism, cytologic atypia, increased mitoses with atypical forms, or sometimes there's a round cell population or some other type of population that's making or producing a woven bone or osteoid, which is the characteristic malignant bone. The bone itself isn't malignant, but the production of the bone by malignant cells makes it a osteosarcoma or malignant bone tumor. Then the low-grade variants look very bland, deceptively so. They have spindle cells that are bland and run parallel to the longitudinal slabs of bone. Sometimes the bone is woven or even lamellar. There might be a rare mitosis, but not usually many mitoses. And in addition, there might be mild atypia, like we see in a atypical lipomatous tumor or well-differentiated liposarcoma that has the same MDM2 amplification. And we may see this in an osteosarcoma, but it's very bland, and it can mimic other benign fibroosseous lesions. There's several subtypes of that as well. Then the other types, including the central, high and low grade, and the surface, paraosteosarcoma, PAR, is periosteosarcoma, which is also a surface tumor of bone and tends to be intermediate grade. It's the only place we actually give an intermediate grade to osteosarcomas, and it has chondroblastic or cartilaginous features. This is also on the surface of bone. Then there's also a high-grade surface osteosarcoma, and finally, there are secondary osteosarcomas that may arise in patients with other either previous radiation or other bone lesions, including Paget disease, infarction, osteomyelitis, orthopedic implants. And these secondary osteosarcomas tend to occur in an older age group than the conventional central osteosarcomas.
I work in breast cancer, and we're always looking for or certainly evaluating after someone's had treatment for a radiation-induced angiosarcoma. And you have to imagine my surprise when I found a radiation-induced osteosarcoma in the breast. And I talked to our imaging radiologist, and she said, yes, radiation-induced osteosarcoma is the most common form of a radiation-induced sarcoma. And that was an interesting factoid to me.
Well, actually, it's not the most common. The most common radiation-induced sarcoma is a very high-grade pleomorphic, almost undifferentiated pleomorphic sarcoma, UPS, that is without bone formation, and then followed by angiosarcoma, and then finally osteosarcoma, malignant peripheral nerve sheath tumor, etc. But usually it's a very high-grade tumor. Yeah, and it has elevated P53, which is interesting. These are found many years after the original radiation, sometimes up to 30 years later. It's very interesting. But it is rare. Osteosarcomas are rare, but osteosarcomas arising in radiation are exceedingly rare.
Oh, okay. I am corrected to the right path now. And this was actually a woman who had Hodgkin's disease and had intensive radiation to the chest area, whereas the post-surgical or the adjuvant radiation in breast cancer is less radiation, but then can result in angiosarcoma. You started to talk about the MDM fusions, and I want to go back to that because, molecular testing is really changing the landscape of cancer diagnosis and cancer therapy. And tell me, so what is the MDM fusion? And tell me more about what's happening with molecular findings and how they're impacting precision medicine and therapy.
Yeah, we use a lot more molecular and bone pathology than we ever have before. One of my colleagues, Adrienne Flanagan, whose name I'm mentioning now, Dr. Adrienne Flanagan from England, she has described many of the molecular events that occur in benign bone tumors as well as malignant. And it's helpful to separate these, especially if you have a benign bone tumor, to make sure it's benign by their molecular signature. MDM2 amplification has been well known to occur in a large subset of the low-grade osteosarcomas, whether they're intraosseous or central, or if they're on the surface or parosteal. And so we do use that quite frequently. It's the same amplification by FISH that we see in a group of liposarcomas. And so it's very helpful to use this method. At our place, we actually don't currently, our molecular lab is being built again with a new pathologist, and we're building up the use of these techniques in-house. But right now we do the technical outside and we read the MDM2 FISH ourselves on these cases. But in general, molecular is used tremendous amount now. In fact, I have a case that is a very challenging case, and I have markers or molecular events that I can use for both osteoblastoma and for chondroblastoma in separating it from an epiphyseal lesion, clear cell chondrosarcoma. And so we have sometimes we use the benign molecular to exclude it from something malignant.
And this is a fascinating area. How does this molecular profile impact treatment? Do you
tremendously.
Yeah.
Yeah,
Can you
tremendously.
About that?
Yeah, sure. Going back to sort of a basic sort of 10-step approach to the diagnosis of bone and soft tissue tumors, I do usually take in all facts into consideration. I usually take into consideration the patient demographics, the age. You mentioned earlier that pediatrics, the tumors are different than the tumors that we see in young adults or even older adults. And location, and particularly location is which bone is it involving for bone tumors, and then of course exactly where it's involving for soft tissue tumors, including the depth of involvement. And we'll talk about that a little bit later. Depth is very important in soft tissue tumors. And then we think about whether it's polyostotic, meaning multiple bones involved for bone tumors, or one bone involved. And so that is, all of these features can be identified by our radiologic colleagues. So the big picture really is our radiologists. We talked about radiology, using that very heavily in bone tumors. In addition, they can tell us whether the bone tumor is breaking through one compartment into another. And so therefore that also helps with our interpretation. We're more concerned about a very aggressive lesion with an aggressive periosteum and breaking into soft tissue from the bone. We also are concerned about larger size tumors. And so all of these things come into play by our radiologic interpretation, which is the big picture, especially if we only have a small biopsy. Then we look under the microscope and try to make a histologic diagnosis. For most conventional osteosarcomas, it's an H&E diagnosis alone. We don't use any special immunostains or techniques. There is an immunostain, SAPe2, that can be used for high-grade osteosarcoma, but it is only telling us that there is bone being formed, and it's also positive in benign bone as well. So it doesn't help us make the diagnosis of a malignant tumor. And so therefore, we really don't have a specific finding. We know that some of the osteosarcomas are retinoblastoma gene involved, or their P53 mutation involved, like leaf-Armani for the retinoblastoma gene. We don't do those markers for osteosarcoma. It's really an H&E diagnosis. But when it comes to all of the other tumors in the differential diagnosis, most of those now have a molecular event. So for example, giant cell tumor of bone has a mutation of H3F3A, and chondroblastoma, H3F3B, and so on. And so this is very helpful. In fact, what you're asking is very important to the diagnosis and the CAP synoptic reporting. And so we are going to be updating the CAP synoptic reporting with clues and with tables as to how to work up some of these histologic diagnoses with proper immunostain and also any type of cytogenetic or molecular studies to help with the diagnosis, because the biomarker reporting is also something that we're working on as well.
That's a fantastic segue into the cancer protocols. I think you're very involved both with, as a subject matter expert, with the protocols for osteosarcoma and soft tissue, and also for the biomarker protocols. Can you tell me how they affect your workflow and how you use the data from them after the fact?
Oh, absolutely. I would say with every tumor that we sign out, I do a lot of surgical pathology subspecialties as well as bone and soft tissue. We use the cancer CAP synoptic reporting protocols. We're also using biomarker protocols, and we've just recently completed, I was one of the primary authors on the GIST protocol and its biomarker protocol, and we updated those. And so we basically use these very heavily. When we're about to write up a case, not only do we do the workup, but I think going through the protocol can be very helpful to folks to think a checklist, a mental checklist is to make sure they haven't missed anything. And particularly going back to bone pathology, we really, some of it can be made on H&E diagnosis, but it's helpful if we were going to get some additional markers, we would go ahead and report those also in our synoptic report, either by immunohistochemistry or by cytogenetics or molecular. So it's interesting because I think we're going to try to put in more clues, and also the World Health Organization classification has been even more complex. There's many more new entities that we've discovered in the world of bone and soft tissue pathology, and this is largely due to molecular events, separating them into separate subtypes. And so now we have additional data that we're going to add to the CAP protocols to help make some of these nuancey changes in diagnosis.
It's fascinating. So many people might say, well, cancer's been around since humans have been around. I look at the history of it, and they have found evidence of cancer in ancient papyri from the Egyptian society. And yet we're finding out new things about it all the time. It's an ever challenging and evolving topic. Let's talk a little bit about treatment, and then we'll switch to soft tissue tumors.
Yeah, absolutely. So I, in preparation for this podcast, asked one of my very esteemed colleagues, who's an orthopedic oncologist at Memorial Sloan Kettering in New York City, Dr. Carol Morris. I asked her to give us a few words about the clinical management and team approach to patient care for bone and soft tissue sarcomas. And I'm going to go ahead and play this, the data that she recorded.
The clinical management and prognosis in osteosarcoma is highly dependent on grade. All tumors, regardless of grade, need extensive disease workups called staging, which includes CT of the chest, which is the most common site of distant metastases, followed by a nuclear medicine scan, either bone scan or PET scan, both of which are acceptable in 2023. Low-grade osteosarcomas are treated with surgery only. High-grade osteosarcomas are treated with a combination of chemotherapy and surgery. Low-grade osteosarcomas most commonly occur on the surface of the bone as opposed to intramedullary. In this example of this tibial low-grade osteosarcoma, given the low grade, we can perform a hemicortical resection, taking out the tumor but leaving the rest of the bone behind and filling that defect with an allograft. Low-grade osteosarcomas are associated with good survival, with most patients experiencing greater than 90% at 5 years. High-grade osteosarcoma, on the other hand, is associated with a high incidence of micrometastatic disease. The current treatment paradigm is to give preoperative chemotherapy, followed by surgery, followed by postoperative chemotherapy. The most common chemotherapy protocol is a multi-drug regimen consisting of adriamycin, cisplatin, and high-dose methotrexate. A wide excision is performed with a cup of normal tissue around the tumor and reconstructed with a megaprosthesis. The 5-year survival for localized disease is approximately 65%.
Oh, it's amazing to me, and especially because osteosarcoma has a pediatric peak, that surgeries have moved from a complete amputation to actually carving out the bone tumor and then replacing it with, I guess I would say, an intracorporeal prosthetic.
Sure, yeah.
Some of the materials. Yeah.
Yeah, the limb salvage procedures are amazing. Yeah. There's also a very interesting surgery. I don't know if you've heard about it. It's called the Van Ness turnoplasty, where if there's a tumor around the knee, that they will take out the knee joint and the tumor, and then they will put the ankle back onto the patient as a new knee. So now when they flex up their foot, it's like flexing back their knee. So it's turned around and put the ankle joint becomes the new knee joint. So it's quite interesting, and the patients learn how to run, do normal activity on a new joint. So it's quite a great procedure.
Oh, that's amazing.
In this country.
That is amazing. Let's switch gears to soft tissue. So can you tell us, let's start with, who are the populations who are affected most commonly?
The soft tissue sarcomas are involving anywhere from very young all the way to very old. And certain types of soft tissue sarcomas are more common in pediatrics, like rhabdomyosarcoma, or certainly in newborns, infantile fibrosarcoma, whereas we have certain types that are more common in older, either I'd say like the mid-range of adults, like myxoid liposarcoma, or even very much older adults, undifferentiated pleomorphic sarcoma. And we tend to have the more aggressive high-grade things in both ends of the spectrum of age. So we can have, although some of the pediatric tumors, including the new fusion sarcomas that are tyrosine kinase fusions, and these are targetable sarcomas, these tend to look a little bit lower grade, although they sometimes can't be graded. Their behavior is unpredictable sometimes, but we tend to have really usually more very high grade and very aggressive tumors in both ends of the spectrum, but mostly in older adults, where there's complex cytogenetic abnormalities that form the tumor.
So that brings to mind a question. Do the pediatric cases have a simpler molecular phenotype in contrast to the adult cases?
Well, that's a good question. I think when we say pediatrics and young adults, that I think several of these tumors will bridge both of them. So if we talk about Ewing sarcoma, for example, That would be more around the teenage years, and those, or the young adult. And those are, generally speaking, if they're intraosseous, and those are one of the prototypical simple or reciprocal translocation or fusion sarcomas. And those are the most common that we see, but we see several other round cell tumors that will occur probably around that young age group mostly. When I'm looking for fusions, I usually get the comprehensive sarcoma fusion panel in patients who are less than 50 years old. Not to stereotype, but usually we'll find more fusions in younger, reciprocal translocations or fusions in younger patients, although that's not true for everybody. Sometimes we just see them in older adults.
I find that fascinating. So how do you approach a soft tissue tumor for diagnosis?
Okay, great question. So going back to my sort of 10-step approach, I also involve the clinical information, demographics, radiology. The gross pathology is so important for soft tissue and bone tumors. I like to see what the margins look like. For example, soft tissue tumors, when they're in the subcutaneous tissue, they're very infiltrative, and it's hard for the surgeon to get around the margin. Whereas when they're intramuscular, they compress the adjacent normal tissue and form a fibrous pseudocapsule. And usually it's easier for a surgeon to completely excise it. And we can look at gross pathology and see if there's a smooth margin to see if it's been completely excised. I know that our margins are different from yours in breast pathology because we just have to have one fibroblast of a pseudocapsule as a negative margin in the sarcoma world. And that's, if there's a pseudocapsule around the tumor, and it hasn't been transgressed by tumor, then that's a negative margin, even if it's less than a fraction of a millimeter margin. So then I look at my microscopic and decide what cell type I'm working with. Is it a round cell tumor, pleomorphic? Is it spindled or fascicular? Is it rhabdoid? Is it giant cell rich? Or is it ovoid, like these new myoparasitic targetable fusion sarcomas? And once I decide that, I apply some immunostains. I have sort of a cookbook that I use to make sure I'm not missing anything. I make sure I'm not missing pleomorphic tumors. I make sure I'm not missing a melanoma or a spindle cell carcinoma, as well as working up various immunostains to exclude sarcoma, particularly CD34 and Desmond. And then just to make sure it's not along those lines. And then I will apply molecular or genetics if necessary, particularly in the round cell tumors. And now in some of these fusion sarcomas, we will get them all the time, especially, as I mentioned, in younger patients. And then we arrive at what's called the phenotype or cell of origin. So what does it most resemble? Does it resemble a vascular tumor with all this information? Are the vascular markers positive? And if so, once I determine the phenotype or cell of origin, then I can assign a diagnosis, I can grade it, and if it's malignant, and assign prognosis. And we advise as pathologists treatment, but we know from what Dr. Morris would say in a second here, I can play her tape, but I can summarize that if we're in a hurry, that basically low-grade sarcomas usually get complete excision, whereas the grade 2 and grade 3, which are considered high-grade sarcomas, usually have pre-adjuvant therapy and post-adjuvant therapy. Do you have a second for me to play what she recorded here?
No.
Soft tissue sarcomas are typically taken care of by a multidisciplinary team consisting of a surgeon, a radiation oncologist, a medical oncologist, supported by a pathologist and a radiologist. Collectively, this group makes up the multidisciplinary sarcoma tumor board. In large academic medical centers, each patient with a sarcoma is discussed in a tumor board setting, where the size of the tumor, the grade of the tumor, the histologic subtype, the presence or absence of metastases, and other clinical factors are weighed to come up with an individual treatment plan. In general, most low-grade sarcomas are going to be treated with surgery and in some instances radiation, whereas high-grade tumors will be treated with surgery, in most cases radiation, plus or minus chemotherapy.
And I can add that with the new targetable lesions, we have some really interesting cases where the tumor, like in the hand around the fingers, was not amenable to surgical excision. It would have resulted in amputation. But now, because this example was an ALK fusion sarcoma, It could be treated with a pediatric 2-year-old. Instead of an amputation, they were treated with crizotinib, which is it's an anti-ALK therapy. And so this tumor melted away within 5 months, and the patient is tumor-free, radiologically and clinically tumor-free, able to use the hand again. And this spared the patient from getting an amputation. So it's pretty remarkable now, these novel fusion sarcomas, that we actually can have some targeted therapy as well, in addition to classic chemotherapy.
That's amazing. So we're going to go a little bit into the cancer protocols and how they help to keep pathologists on track. So you just mentioned how important the molecular findings are to guide the therapy. And I know that you're on the biomarker task group. Can you tell me a little bit about how the cancer protocols might help in making sure that this information is being collected and that the patient-facing clinicians are able to access it for treatment purposes?
Absolutely. I think that the cancer protocols are helpful for everybody, including trainees, residents, staff, even experienced staff, because it makes us do a checklist and make sure that we haven't forgotten anything. Basically, for the, I guess I can start with the bone protocol since we did that first. It's very helpful to know, of course, the radiologic findings, as we talked about. And that's one of the features that is in the CAP synoptic report. And it's helpful to put that into the report for everybody else to make sure, because let's say we think there's an osteosarcoma, we want to make sure that it's a metaphyseal big tumor that's breaking through into the soft tissue with a classic Codman triangle. Those are going to be features that we're looking for in order to support our histologic morphologic impression. It also puts in there to find out if the patient's been treated, because for resections, treatment is really an important thing in both bone and soft tissue. And treatment is measurable not only by necrosis, but also with some of these newer targetable therapies. We see more of a fibrotic picture. It changes the tumor. It makes it hypocellular. It sterilizes the tumor, so there's less mitotic activity. And we'll see smudgy fibrosis sometimes instead of necrosis. And those all count as treatment effect that we will note the percentage of. So it's helpful to know what type of treatment the patient received before receiving one of our specimens, particularly for the resections. And this goes for soft tissue as well as for bone tumors. It's helpful to have the checklist because you need to know exactly where in bone where the tumor is located. Is it in the epiphysis or metaphysis? And that helps our diagnosis to know these specific features. Where is it exactly located? And then finally, there's a nice checklist of all of the malignant. And now in soft tissue, we're going to include the locally aggressive or low-grade borderline tumors in our synoptic report, because these are also important, and these do get sometimes additional adjuvant therapy. Even tumors such as fibromatosis, which is a locally aggressive benign entity, but it can actually be so aggressive that it can wrap around vital structures and cause patient death. And therefore, sometimes these are treated with radiation or other modalities, other types of medical treatment. And so basically, we are including several tumor types in the new upcoming version. Once we decide the histology, together with our morphologic impression, the immunophenotype, and any type of molecular or genetic studies that we do, and we can talk a little bit about new modalities, maybe at the very end, but we can go into talking about the grade. The grade is important, particularly for guiding treatment. In osteosarcoma, we really only have low and high grade, but we have intermediate or moderately differentiated in some of the other subtypes, as well as some other sarcoma types. Mitotic rate is important. Necrosis is important for grading purposes. Lymphovascular invasion. Aside from a couple tumors that mimic melanoma and carcinoma, namely clear cell sarcoma and epithelioid sarcoma, and also sometimes rhabdomyosarcoma, most of the sarcomas are hematologically spread, so we don't actually see lymph node involvement, but we do comment if lymph nodes are involved, or if they happen to be in the specimen. They're not usually taken with the specimen, but sometimes if we have an amputation, we'll comment on the lymph nodes. They're usually negative because it's not lymphatically spread. The most important that we're coming to from a pathologic standpoint is our PT pathologic stage score. And in bone tumors, this really depends on site. It depends on whether it's appendicular skeleton, trunk, and facial bones versus whether it's in the spine. Those differences would be between measuring size versus measuring segment involvement. And the same goes for the pelvis, that's separated out. And I think those are helpful for the pathologists and the trainees to look at these protocols in order to properly give a pathologic staging. In addition, we look for metastases in these tumors. Often at the time of resection, the reason the resection was done is because there aren't any lung metastases, but we do occasionally get, and for example, in pulmonary, we would get maybe a osteosarcoma lung metastasis, and that would change the M staging for the pathologic stage.
So is lung the most common site of metastasis?
For osteosarcoma and most of the malignant bone tumors, lung is the most common site for metastasis because it is hematogonously spread. Sometimes we have other soft tissue sites as a metastasis as well.
Yes, I know in breast, I've encountered a few sarcomas besides the radiation-induced angiosarcomas. I had the radiation-induced osteosarcoma that I mentioned, and then I also recently had a malignant phylloides tumor that had transformed into an osteosarcoma. It's pretty fascinating to see those. Quite something, but in breast, it seems like it doesn't matter what your tumor is, they're going to do a sentinel lymph node. And I always think, and in these soft tissue tumors of the breast, why?
Yeah, right.
Yeah, they've always been negative. I just want to mention that the College of American Pathologists is going to hold a user group summit for people who use or are thinking about using or wondering what the value is of the electronic cancer protocols. This we're calling a Cancer Data Summit, and the title is Leveraging the Power of Pathology Data. It'll be held this October 6th in Chicago, just preceding the CAP annual meeting. Do you reuse any of your data? Do you go back and say how many cases of this type, that type, or for quality, how often was this molecular test performed?
Absolutely. We use these protocols all the time. And so basically, this is one way that we can, in addition to the top line diagnosis, this is one way that we can actually search for research purposes or for data purposes. I know that we do sometimes use this significantly. And I know that many of the epidemiology studies are based on some of the CAP synoptic reporting. The reason to do CAP synoptic reporting is really to have it standardized so that we can go back and look at some of this data, and it's all going to be standardized and easy to search for. And so I think that's also very helpful, in addition to a checklist for people to make sure that they write all the, don't forget anything in the diagnosis. And it's nice to have it all in one place in a synoptic reporting area in the report. I was going to mention that currently many of the systems that we use for pathology at various institutions, they all have vendors that will have the CAP synoptic report put into the system. And so when we update the reports, there might be a little bit of lag time. And so sometimes we will go on the CAP website to look for these protocols if we don't have the most updated version, although most of them are the most updated version, but there is a little bit of a lag time after a protocol is updated. And so it is helpful sometimes to check the most recent protocol. I know that we just updated all the pediatric protocols recently and also a few of the other ones. I was going to mention for soft tissue pathology, we also have a similar importance in the PT score or pathologic stage classification, particularly as to site, just like for the bone. So head and neck tumors get a different scoring system for T-score than trunk and extremities, abdominal, thoracic, visceral organs, retroperitoneal, and even orbit. And so all of these from head to toe is really included in soft tissue pathology. And that's important for most folks like yourself and others who practice other subspecialties to know that they can use the soft tissue protocol for various other sites as well. If it's not in an organ, there often will be, this can be used for various locations in other subspecialties as well.
Yes, I guess it's the only other protocol I've used in the breast besides the breast protocols is when I have a soft tissue tumor or some kind of sarcoma, include that protocol. So before we close out, is there anything else you want to say?
Well, I just wanted to say that these two fields are rapidly evolving, and I think the CAP protocols and their updates are going to be important to catch everybody up to the latest and the greatest. And we now have new techniques. When I first started practicing pathology many years ago, I started off at the Armed Forces Institute of Pathology for many years, and I worked with Dr. Enzinger, and he used to make the classification based on the morphologic impression alone. He didn't have any immunostains when he started doing he's really the grandfather of soft tissue pathology, and he didn't have any immunostains back then. But his observations have withstood the test of time. We've just made a few tweaks based on some of the molecular and breaking things into some subcategories. Along the way, while I was there, we developed more immunostains, and we went from using mostly PCR to mostly FISH. And then the newer technique that we've used in the last 10 years has been next-gen sequencing, which has really tremendously changed our diagnoses and findings. And we'd be surprised, we're finding new novel fusions all the time by using next-gen sequencing. And then also the newest modalities might include methylation profiling, which hasn't become very big in this country yet, for soft tissue tumors. It's used for CNS and other areas, but several of our European colleagues are using methylation profiling for all of their tumors, bone and soft tissue. And so we're able to sometimes find out more information from those studies. And finally, this whole role of AI, I think soft tissue and bone still is going to require pathologists, because it's really an art as well as a science to make a comprehensive diagnosis. And there's a lot of nuances in the field. And I think that, certainly if this is probably one of the biggest areas that gets consulted on is the mesenchymal lesions, because these are rare and often very challenging, and reactive things can mimic malignant and vice versa. So,
and I want to underline that, rare and very challenging. So I admire you for persisting in this field, and I want to thank you for letting us know about all the new changes. I do want to mention, you talked about the CAP protocols being updated and how there's a lag time before they're updated electronically in a vendor-supported laboratory information system. But the paper protocols are updated usually about 6 to 8 months before the electronic protocols are updated, but the vendors have 6 to 8 months to implement them. But the paper protocols updated are available online on the CAP website. And if you're a CAP member and you have the MyCap app, you can actually find them on your MyCap app. And I've used that quite a few times. Thank you so much for taking some time out to teach us about bone and soft tissue tumors and to let us know what's happening molecularly, treatment-wise. It's fascinating and wonderful to know, and for talking about how you use the electronic cancer protocols. So Dr. Julie Fanburg-Smith, we thank you for being our guest on this podcast.
I want to thank you both for joining the podcast to talk about Sarcoma Awareness Month. And I want to thank you all for listening to this CAPcast. You can find links to the cancer protocols that were mentioned in the episode description. And for more information about the CAP, visit cap.org.